I'm going to introduce Dr. Wisal Ahmed, who is visiting us from Ethiopia, where she's based with UNFPA, which you'll say the name is
United Nations Population Fund. Ignore the F.
Okay. United Nations Population Fund.
Yes,
And I don't know what the A is, but that's all right.
Just ignore that.
Yeah, where she is overseeing the female genital mutilation program. And we're going to hear about that and all the work you've been doing kind of leading up to that maybe a bit.
Yeah.
Okay. So please take it away. And yeah, well, I think we'll have good time for interaction and questions. Because I told Wisal not to talk the whole time because we'd have lots of good questions.
I hope so. And I'll wait for people to join. But yeah, it's so nice to meet you all. I was just reminiscing that my relationship with the University of Washington is 24 years old. I came here in 2000, so I'm really back home. Thanks to Carrie facilitating this presentation. So yeah, my name is Wisal Ahmed. I am an alumni. I did the MPH in epidemiology through the IARTP program and PhD in implementation science from the same university. I'm a medical doctor by training and have always been interested in women's health. But the last, 7 or so years, focused more on female genital mutilation. Worked for WHO, where we worked with the health sector response to address female genital mutilation. And now I am working with the United Nations Population Fund to have really oversight on a multisectoral, so it's not just the health sector, but many sectors, response addressing FGM in 17 countries. So yeah, so it's a big responsibility, but it's also a very interesting area of work. And I'm hoping actually through my presentation to have people interested in this area and work with us in strengthening, I think, the evidence component in FGM programs. So I want to now I need help.
In Leo's, they can see her too.
Yeah. So share.
So yep, share your screen.
Yeah, we did that. Okay. And this. Yeah. Okay.
I'm going to turn on your video. Well, okay. That way folks can see.
Okay, so my presentation is entitled, Do We Have the Right Markers for Interventions and Impact Measurements on Female Genital Mutilation? And, okay, how do you do this, enter? Sorry about that. Okay, great. So I will just give a brief introduction, a global overview on the FGM abandonment progress, something small about what I am currently doing, and try to answer why is there progress, what works, what are the measures that we use for interventions and impact, and share some results of an exploratory analysis that we have done recently. So female genital mutilation is a harmful practice as defined by the World Health Organization, is a harmful practice which involves partial or total removal of tissue or other injuries to the external female genitalia. It is really a global problem. It affects over 200 million girls and women. There's an estimate of over 8,000 new cases per day. So today, before you sleep, 8,000 new cases have occurred. And it leads to several immediate, short, and long-term health complications that have a whopping health cost of $1.4 billion per year. If you look at the map I can't, the cursor doesn't show here on the screen, but on the left, sorry, oops. On the countries that are mostly affected by FGM are mostly in Africa and what we call the Sudanic belt. It extends from the west to the east coast of Africa. And the different colors just show how high it is, what's the prevalence in these areas. The red, just like the traffic, is danger, it's over 80%. And the ones that are shaded green are countries that have an FGM prevalence of less than 10%. As you can see, there is a wide variability between countries. And it's not as simple as that. There are also at subnational levels variations. So if you look at the other map on the right, it's not all red. For example, in Egypt or Sudan, there are some patches where it's less concentrated. So yeah, so it's not quite uniform. There's several origins on about how FGM came to be. Some people talk about it being among the Stone Age people in Equatorial Africa. Some think it's started with the Egyptians. It was found in mummies, what they call the pharaonic circumcision. Some thought of it as, or believe that it's part of slavery trade, because sort of to ensure virginity, you get higher prices, you know, for girls sold at that price, and others just think that it just arose independently in different communities and it's sort of spread, assimilated, adopted by different people as they moved around. So why is FGM practiced? It is a social norm and it is done because you want to be socially accepted. And also this fear that if I don't do it, maybe people would not accept me. And there are several beliefs around that. Some do it because they feel that it ensures, as I said earlier, premarital virginity and the concept around honor, preserving family honor, and also as a marriageability criteria. If you have undergone FGM, you are going to be married. And also related to marital fidelity. Others perform it because they believe it's a religious rite or a rite of passage to womanhood. And it's really to uphold cultural ideals on what is thought to be beautiful, feminine, or even for purposes of cleanliness. So many factors on why it is practiced, and it varies amongst different communities. The main practitioners of FGM are traditional, but there is an alarming involvement of health workers, what we call FGM medicalization. You can see on the map, there are several countries that are having sort of a high involvement of health workers performing this. Guinea is one of them, Nigeria, Sudan, and Egypt are the big ones, and so is Indonesia. Indonesia is quite populous, so you could imagine the number of girls and or health workers performing that. And health workers are involved because they are part of the society, so they're upholding the culture. But there's also financial benefits to it. But it's not, it's not unlawful. So they perform it. They think it's a part of harm reduction instead of a traditional practitioner doing it. If a health worker does it, it might be safer in quotes. So several reasons on why health workers are increasingly getting involved. But FGM violates several human rights, starting from gender discrimination to life, to health, to the rights of the child, because it's performed mostly between the ages of 5 to 9. So it violates several human rights, and there is, I would say, good consensus on why it should stop, not continue. So I'd like to just now move on to just give you a global picture of, how is the world doing with all these figures that I've shared earlier. FGM is actually becoming less common, and there is growing opposition. Girls living between 15 to 19 years old have affected by FGM have reduced from half to a third. And there is also the number of girls and women who believe that it should end have also doubled. So if you could look on the graph, you could see the attitudinal change from 2000 to 2020, from 27%, it has doubled. So there is progress. People are changing their attitudes and changing the practice.
Is that first bullet worldwide?
That's
49%
globally.
Globally,
That's
49%
globally.
of girls.
That's globally.
Now third.
Yes, yes. So there is progress.
Progress, but still, that's a pretty
That's-
shockingly large number.
Yes, yes,
Of
yes, yes,
girls
yes.
in that age group.
Yeah. I mean, from the countries that practice.
Oh, okay.
Yeah, there was
These are
the 31
percentage.
countries.
Okay, it's
The
not
31
count.
countries. No. The 31 countries that perform, or at least we have data on them.
Mhm.
These are the figures. So there is a reduction in that. Again, just another graph to show the intensity. If you look at the graph, the map, or 30 years ago, but that's even more now since the publication is 2020. But you could see that some places that have been blue. Look at just the blue color; it's shrinking, right? The blue is shrinking. If you go from 30 years ago to today, the blue sort of like surface area is reducing. So there is reduction, but it's not reducing in a uniform way, or it's shrinking slowly. Actually, to be honest, it's shrinking slowly, and we do have what we call the Sustainable Developmental Goals. By 2030, the goal is to have it go to zero. And if we are to reach that goal, we're supposed to accelerate in, progress or abandonment by at least 10 times the current rate. So we're really pretty behind. Progress is there, but it's really slow. And yeah, so that's yeah. So what is this joint program that I'm working in? It's actually the largest global program that addresses FGM. It started in 2008. It's a joint partnership between UNFPA and UNICEF, and is supported by multiple donors, and several interventions are implemented at global, regional, down to grassroots levels. We focus in 17 countries, the yellow countries. This is the focus. The purple countries, we call them the global influence, where we share knowledge and technical support, but we don't necessarily have interventions implemented at large scale. We have several achievements. I am not going to go through all of these, but I just wanted to show that we're really talking about reaching millions of people, whether it's through services, through social media, involving them as change agents. So we've done a lot intervention-wise. So I've shown you the progress, right? We are progressing, but we're not progressing as fast as we could. So that it makes people wonder, so what works? Like, what works? And whatever that works, we should scale it up so that we can meet that SDG. There was a systematic review of literature, a mixture of qualitative and quantitative. There's very little literature, as you will know from my PhD, on interventions. And what was found is that community level interventions are, I would say, promising. They're called successful, but they are promising. And legislative interventions on the top, they call them promising as long as they are brought together. You can't just put a law, you have to have several interventions in place. Service level, shown that training healthcare or health workers to be change agents is suggestive to be successful. So there's health workers, there's community level interventions, there is education of girls as potentially a good intervention. So there are several interventions that have shown some sort of success, but really at small scale, not put to scale. This one, I'm just going to skip it, but maybe in the questions. So what are the intervention measures? You've seen that very busy table. I really want to stand up, but anyway, the measures of success are usually outputs like numbers of people trained, those who've received services, engaged in any of the activities. But it really boils down to what is changes in knowledge, attitudes, intentions, and obviously to practice, right? Prevalence. And what we call the FGM risk incidence. So what we did, we tried to see what were the factors that were associated or could be associated with attitudes and practices. And we just did a simple correlation, just looking at the factors to see if they determine attitudes. Law, remember there's one about the success in law. You know, education was also one that was found to be a success factor. Law, there's also the religious part of law. We were also trying to examine that. And we wanted to see if even our program itself, this joint program, could be associated with any of attitudinal or changes or in the countries that we worked with. So we, first of all, the sample is very little. You're really talking about 31 countries because we're looking at national data. And what we found that's sort of indicative, like FGM low duration, could be associated with attitude. But the rest, there was very low correlation between these factors and attitudes. And this is DHS data. So we looked at the FGM prevalence. We looked at FGM attitudes. So our FGM attitudes, determinants of FGM prevalence, and whether the FGM low duration has any association with FGM prevalence. It's so not very promising. No, not very promising at all. So, so the FGM attitudes, girls and women who do not support FGM was negatively correlated with FGM prevalence, which makes sense, right? Yeah, if I'm not supporting FGM, it means FGM prevalence would go down, right? And this one is a bit complicated because in surveys, you ask the people right now, what is your attitude of towards FGM? But the FGM prevalence is really something that happened 15 to 49 years ago. So to me, this doesn't make sense. Like, I mean, it does show some association, but it just doesn't add up. And then when we looked at FGM low duration, it's positively correlated. So again, it makes sense. If you have a low, the longer you have it, it's supposed to be negative. You have FGM, but FGM laws are not really enforced in any of the countries. So you have a law issued, and it could continue for 20 years, but it's not effective. It's not being utilized. Just a law. So it doesn't have any impact. To me, at least from a programmatic point of view, they are not enforced. So I don't know how this association came to be, but it does not negate the fact that FGM laws are not effective.
What would be an example of an FGM law country? You cannot. Do they target medical professionals, or is it?
It's everybody. Everybody. Parents can go to jail. Okay. Yeah. Whoever made that decision, took that girl would be put to law, to court or whatever. But then there are so many, it's so complicated because they are the primary caregivers and we don't have social protection services. So it's very hard to report on your parents, that's one. And even if they do, the system does not support it. So most of the time, if it is reported to law, to legal services, it's never taken to another step, like they don't put the parents to jail. And yeah, so
They don't.
so education is not a measure of how
The people who are doing it.
also they pay money. They
But it
pay
seems
money
like
or
you
put
put
people
them
in
in
jail.
jail.
Yes, to put
Right.
in jail.
The medical practitioners or
The medical practitioners should be receiving the severest, the most severe punishment.
have their license revoked.
Because they have the do no harm oath, and so they're supposed to, but again, because it is a complicit agreement between the family, it's very hidden. Chances of it then being caught is very low. So it's very hard to apply the law. It's very easy to say it's like there is a law of the land, but to apply it, because it's really a complicit agreement, it's agreed between two parties, it's very hard to be reported unless you have some sort of a police, a community police in place. So having a law does not mean it's being applied. So and to me, even even if these associations were there, they are very weak. The effect size of that association is so weak. I'm not very motivated with attitudes and law. So we don't know. We don't know. At least from population data, FGM prevalence and law, at least, or attitudinal changes, if there is anything to see. So, so what are the next steps? So as I mentioned briefly, FGM prevalence is really the number of girls and women who have undergone FGM over time. So it's a very it's very hard to see changes over time because you really have to have cohorts dying off to see some sort of like fresh. So people nowadays are working on what they're using the data to do survival analysis to estimate the risk, because your risk changes with time, depending on culture too, right? If I exited maybe the 5 to 9 risk area, maybe and this is where it's most commonly performed, my risk will reduce. But then some people have it after 14 years old. So risk could be a better, well, it is a better measure of FGM. So if you would like to measure impact, probably this is the measure that you would like to use. We are trying to compile all the data on people involved in all of these interventions that I've described, but we also would like to look at their impact at subnational level, because right now we can't quite see the effect at national level. So so the next step is try to understand the association at subnational level. So this is where we are at, but I just wanted to sort of like, just show that there's so much to learn or so much to do in this area of work. And it's so much needed because now we're approaching that SDG goal. And this is where I'm just looking at, all the students, faculty here, to give me a call so that we can like sort of like think together, like how best can we measure interventions, their impact, so that we really know what to put to scale, because we can't really we have very little resources and we can't spend them, without really knowing what is effective. So I'll just end at that, really. And I thank you all for your time, and look forward to your questions. Thanks.
Yeah, I have a question. When going back to your last slide, Wisal, when you talked about survival analysis, I wondered if there's sort of an age by which if you haven't experienced FGM, you're just not going to. So, and how different that age is across the focal countries. So could you have a measure, basically, could you focus on the youngest cohorts and say, FGM by age 20? And you're looking at a prevalence that's really limited towards the youngest population or the younger women, so that you have more of that kind of closeness between the interventions and then the outcome measurement, as opposed to that, FGM among all women, like you said, then there's, you don't want to be surveying the grandmothers to know what their FGM status is. But how different is that kind of maximum age of FGM across the countries?
I mean, traditionally, what they do at surveys, they limit it up to 14 years of age. But we know some countries in West Africa, it's beyond the 14 years. So now it's trying to narrow down to the 20. Probably 20 is actually a good
or 16 maybe,
or 18 consent, around consent, yes. But yeah, so this is sort of the challenge. Yeah, as you said, what I am measuring now is not necessarily a result of the intervention that I'm doing now. It's probably a bit historical. And this is sort of like, it's really very confusing. Like when you do a program and then the donors say, so what are the changes? What are the changes right now in the practice, right?
You have to ask women, so it's not an exam or an objective.
No, it's verbal.
Yeah, so people might not be fully reporting as well.
There's a bias there. That's also another problem. Some biases, the verbal reporting. Some people are very concerned, especially when there's a law. They're very scared to report.
Yeah.
Because they don't trust, the interviewer. They think they'll probably report them and they'll put them to jail. So there's this issue about that. And and for girls 0 to 14, you ask the mother, so it's not the daughter. So there's also the honesty. I would ask the children because chances are they would. So so there is a lot of
That's I have a couple questions I don't want to forget, so I'll ask, and then we can go to the online questions. I see Scott's finished his lunch. He always has a lot of questions. So I guess my questions are around the interventions part of it, and the first is, are there other, what we would call this, harmful practices that are similar to FGM that you could use and learn from? I'm just racking my brain and I'm not really coming up with them. It just honestly just seems so.
That's one. Okay,
Yeah,
I'm
that's
writing
one.
a question. Okay.
And then the other is, have any countries tried a harm reduction approach that would be, okay, the government is going to offer this in the facility that's like a lesser form of FGM, like just a little cutting, like you know what I'm talking about.
Yes.
Like not doing like the back to your dissertation.
Yes.
And tried to change the practice on the physical side, but retain the cultural, religious, other aspects.
Right. That's the second?
That was it.
Yes. Okay, good. So I don't know if it's really the closest, but usually female genital mutilation is, I don't know, they think, well, child marriage is sort of like put as another close relative of female genital mutilation. The thing is, the interventions for child marriage, I don't think they are as old as the female genital mutilation interventions. So it's sort of like, I don't know, but I'm not an expert in that area, but the literature is still just not as strong as female genital mutilation interventions. And it's really interesting. Most of the research around harmful practices have been mostly anthropological. So people were trying to understand why. why is this practice done?
Yeah.
You know, and so there hasn't been so much evidence around interventions, and people really didn't. Yeah, it was mostly descriptive. So the interventions have come, but even the studies around it haven't been very strong. So child marriage is one. I don't know another that could
Maybe
be
like scarring, I
equated.
guess, I'm just thinking of
Or
how we-
the
The
infant
scarring?
feeding, would there be any infant feeding that's practices that are harmful? that
They,
are
they, they
changed?
also, they give this equivalent of, yeah, in China, they used to foot binding.
Foot
binding, right.
Yeah, and they felt the community, I think the community declarations or something was a very strong intervention, and that was sort of borrowed into female genital mutilation. It's really one of our major interventions, but for me, we're yet to see the strong evidence to show that it really works. For me, I find female genital mutilation or just the female genitalia, because it's hidden, it's a taboo topic. It's very hard to address, and it's around sexuality. Very hard to address, around religion. So the drivers are so hard to sort of address, right? Yeah, so, people have done, religious leaders' involvement and all that, but it's still very slow. The interventions haven't put the scale to sort of see the effect. And as you well said, the prevalence, the measure of prevalence isn't great, right? To sort of like, how could you go back in time and measure? And usually interventions don't have very good programmatic data and monitoring and evaluation data to sort of like use over time. So yeah, data is really a challenge for us. This is one. Harm reduction, a very good example is Indonesia. It is really, when a girl is born in a hospital, part of the delivery, sort of like care, is to pierce her earrings and also perform FGM to her by a health worker. Egypt also, they've involved health workers to do it, in fact, doctors. And as you've seen in the map, it's still red. So it just reinforces. Actually, I think involving health workers is the worst thing you can do as a harm reduction.
It's much something to replace it, but not really. It's like,
But
okay,
it enforces it. Imagine a health worker. A health worker tells you
Yeah.
what to do, and we believe in health workers. So if you give them it endorses the practice, and people think it's really safe, and it kills. There was a case in Egypt that, a doctor did it, and the girl died. So it's not safe. It's definitely not safe. And the female genitalia, especially when it's done when a child, the baby born, they're amputating. They're not like doing anything. It's really bad damage. So yeah, and we've shown from the systematic review, alternative rights, harm reduction don't work. That one we know. That we know.
Okay.
That we know. So it's really towards zero. It's this or zero. No lesser forms. That's not.
All right, questions from the Zoom room?
I have a couple of questions. Wisal, thanks so much. It's wonderful to hear what you're doing right now, and that was a really nice talk. Are you all able to hear me okay?
Yes, absolutely.
Yeah, okay. One of the things that I was wondering is just a follow-up to what Nancy was asking, which is specifically whether the DHS data are collected in a way or could be used in a way that allow you to look at FGM prevalences across different age bands to avoid sort of the massive cohort effect that you see when you look at countrywide prevalences.
Yes, DHS data is actually in 5-year age groups, so you do have that. But the problem is that, if I look at just the it's not confirmed, like if a girl exits 5, that her risk like is 0, you know, because different communities have different age groups. So even if I do it at smaller age groups, it's not gonna be, it will not capture the full picture, because we also seeing trends that FGM age, the age of performing FGM is also shifting. So it's very weird. Like before we thought it was 5 to 9. That's where most of the girls undergo FGM. But now, because of law and people don't want to know that it's being done, it's shifting to lower age groups. So now it's really a guess game in a sense. So we need to be sure, at least by 14, she has not undergone FGM, or by 18, she has not undergone FGM. And even, you know, I've talked to some demographers, like, why don't we do that? And their worry is just samples. Everything becomes smaller and smaller. You know, when you break down the samples, like, you know, age groups, yeah, then you can't quite look at associations. So, yeah, but that's a really good question. Yeah.
I guess I would think that there would be, on some level, that at least within countries, you would be able to compare data over time in the different age bands. And the shift in timing of FGM would be potentially problematic, but you could potentially model that in as well.
And they have done this. They have done this. We do look at trends over time on the 0 to 14 and also the 15 to 19. We look at those trends, but those trends are also not very rapid. They're not very rapid. Yeah, but we do that.
Great. Any other questions?
I have another one that's kind of measurement oriented.
Yes.
Yeah, so you're talking about attitudes, you know, those attitudes measures, and how, like, you're not so satisfied with that, you know, attitudes as a predictor, right, for all the reasons you've discussed. Is there a good linkage between, like, measures of intention versus what actually is done? I just think about, you know, this was many years ago. I lived in Mali, and I think there it was often like early teenage girls. And, you know, maybe the girls would be very opposed to it, but they weren't in control of their own bodies. And maybe even the parents would be kind of opposed, but then it's like the grandmother or you know, somebody else influential who can all of a sudden kind of flip it and make it happen, right? So I guess I wondered, like, are there measures of intent and how closely that's correlated to whether or not it happens for a.
Yeah, okay, I would also like, I remembered another paper, but yes, we don't measure in the DHS intention. It's really, are you supporting of FGM continuation versus not? Do you think FGM is a religious requirement? So yeah, but then
Yeah,
do you intend to perform? That's a very good, yeah, that's a very good
Because I
one.
think it could be very different also, like,
Yes.
do I agree with it in general versus am I gonna do this for my kid?
That's it. But there's also another very interesting sub-analysis of DHS data. They looked at couples, parents, discordant couples, when a mother is supporting of FGM and a father is not, for example, and what is sort of the likelihood of a girl undergoing FGM. And they did find an association that when a mother is supportive of FGM, there is a higher likelihood of a girl undergoing FGM. So it seems that mothers, to me, yeah, so the attitude is there and there's a higher likelihood.
Yeah,
So this one has definitely shown.
yeah.
Yeah. Yes. Yeah. But for me, it's now, I am sort of like stuck with are our programmatic interventions leading to attitudinal changes? And then we could make that leap of belief that attitudinal change leads to practice.
Following this logic of it being the mother, it seems that if girls are in school, that might be a place where you could talk to them, because they will be future potential mothers.
That's it. And
Is it part of the curriculum? I know it's really hard
It
sometimes
is,
to get
it's
sexual
part of the
recruitment.
interventions, it is put in a curricula. But it's also very interesting from the DHS data, the attitudes of younger girls, 15 to 19, is comparable to older age groups. Like I would have thought like younger girls would be opposing FGM. And it's very worrying because this is the generation to be of parents. So if they do carry the same, beliefs, chances are. So yeah, but that's it. The idea is to sort of like break that vicious cycle, try to give them an education. It's very developmental, right? So you have to get all the girls educated on FGM. To do that.
Question from
Yes.
Robbie. Robbie, do you want to go ahead and ask your question? Hello.
Yeah, well, hi. Thank you for coming, Wisal. You're welcome. Hi, David, and hi, everyone. Well, mine is like, I just wanted to make a comment on the, 15 to 19 acting like moms, and then if mom is supportive. I feel like, at least for our context in Nigeria, I know that the dynamics of, the reality of life, okay, is the natural order of things, this marriage thing. So from that age of 15, they're in low resource settings, and in a lot of settings that continue to perpetuate FGM, there's that worry about, the natural transition for a girl at puberty is for this girl to get married and move on. So if that assumption is carried over, and all this girl, mothers are worried, this girl needs to get married, I need to get her a good husband, dowry will be bigger with FGM. I feel like, and girl is going to senior secondary school, maybe the schools are underfunded, girl is not doing well in school, her mind is of course going to also start to see like, mom is telling me the truth, this is the reality, and this FGM is going to set me up. Then they would volunteer and continue to go with the FGM. So I find that dynamic, is very important, and it's just the perpetuation of patriarchy and so on. And even though the mothers are doing it, but all the time they'll tell you like, I don't want my child to be a prostitute, or I want my daughter. Yeah, they believe FGM curbs down sexual appetite and so on, and so daughter will not be a prostitute. So they believe that it's widespread. And then girls want to be set up to be married. So even if, in the beginning, so I think intervention at school level should be more of like, when do we intervene? And are our schools actually, in fact, equipped? If I go to a private school, it's well funded, my life is good, I feel like my mother is working and doing things, then I will, stand against FGM. But if I look around and I see that in my community, all these schools are dilapidated, and this school is not going to do anything for me for my future. And in fact, I am like happy as a girl that I have this as my livelihood, this marriage. People see marriage as a livelihood and social security. So then they will continue to, perpetuate these cycles, and they would want to continue. So I think there are two very different realities. I know in my community, FGM has become something that they do in babies. So you don't even know it happened to you. Also, people no longer cut, teenagers. So they are cutting babies now. In fact, the way that they would come shave their hair, before the 7th day, they would use that same opportunity. They will remove the uvula, and they will also cut for the female. They would, I have no uvula, Dr. McLeland. I tell you this. I can't pronounce certain things. It's true. So I think there are two very different realities. So socioeconomic status is very important. If somebody is poor and their natural transition is this marriage is their livelihood and that is their future, then this FGM will not go. And if we're using legislation, then we're only just criminalizing poor people. But if we are fixing schools and we're ensuring social security, not only FGM, child marriage will also go. And we saw that with COVID. The moment COVID happened and people were not going out there to mind their business and get their money, we saw that they started to marry off children, not only in Africa, but also in India. So I feel like this is very important, looking at the socioeconomic factors and how they are factoring into all these problems that we have in societies, especially in low resource settings. And this is the same thing with when a Somali mother takes her daughter to Somalia in the summer, her daughter who is 17 or 18, to have FGM done. Is still thinking about, we're in this low socioeconomic setting, and my daughter, I want her to marry somebody that is in my culture, and I know that FGM is having value. So we need, the men to remove this value from FGM. I feel like that's the way we should think about it and think about socioeconomic status. And thank you so much, Wisal, for coming today. I apologize for coming late. I was very excited to meet you. Thank you.
Thank you, Ravi. I mean, okay, what I'm trying to challenge here, even in my presentation, and maybe I didn't put it very strongly, and I need to maybe share more data. The reasons for FGM, or what's driving FGM, is really diverse in many communities, right? I mean, if we look at DHS data, yeah, it shows us consistently that it is associated with socioeconomic status. It's associated with education. But, it's socioeconomic status and education are, I don't know, intertwined. Poverty and education is intertwined. And there's rural versus urban. But then in some countries, there is no difference between rural and urban. There's no difference between socioeconomic status. The rich and the poor do it. So it's not even a poverty question or an education question, right? So what really troubles me is, it's not troubles me, but it's so complicated that you can't really have one singular intervention or even one singular driver, right? You can even have in a family a sister who decides the same genetics, right? The same household, the same exposure. But she decides not to have her daughter undergo FGM, and one who really believes that to have. So like this, it's so complicated, and that's where, like, what can we measure? What can we measure that will make sense and monitor over time and say, okay, this is changing, right? And for us, the behavioral science, there's the theories of, okay, knowledge translates to attitudes, translates to practice. But is that really what happens? I always say at the beginning of the year, I always promise myself I'll do so many things, but do I? I intend.
That's true.
To do something, but I don't practice it. So so for me, because it's so diverse, the drivers are so diverse. I was challenged by a publisher. He tells me, I don't think interventions work. It will just go by itself, and that's where I'm so keen, like, let's measure the interventions and let's see, do they work or do they not work? But then, we're living in such a complex, by the way, it's from Nigeria. And there is also this norm that we have, and it's very common even with Sudanese, where we have these gashes on our face.
The facial markings.
The facial markings. And it just disappeared. We don't know what intervention happened, and maybe we need to study this some more. But it was a sign of beauty. It was a sign of identity, but it just disappeared. So there is this sort of, like, even theory of, like, do you really need an intervention for a social norm to go? It's just that this is quite harmful because it affects, if you're in the health, it does have a lot of health complications, and it really stretches these low-income countries some more, right? We're spending so much money. So it's not because it's, and they do the worst forms of FGM that you really have to kind of like want to stop. So, and that's why I'm really keen on trying to, measure the interventions, their effect, so that I don't keep on repeating. And some people they really strongly believe we should do this. I'm like, where is the evidence? Where is the evidence? Yes.
Thank you.
Thank you, Ravi.
Thank you. So,
Hi, Wisal. I'm not sure if you can hear me. Can you
Yes,
all
I
hear me?
can. Yes.
Okay, great. Okay, thank you for your presentation. So my name is Absa. I co-founded the Washington Coalition to End FGMC, which is a survival-led coalition that worked to get Washington State to pass a law that prohibits the practice in the US. And in April of this year, we got the bill passed into law. And I just wanted to speak on the issue of the gap in data, specifically in the US. And I wanted to hear from you whether your work looks into the US at all. In doing this work, what I have come to learn was almost all the data, research data on FGM in the US has focused on African immigrants who come to the US and children born of African immigrants to the US. And the problem with that data was that it had huge implications for both those who were counted in that data and those who were not. In many ways, it left out white individuals who practice FGM. And we know that today, because many of them are coming out to share their stories, it left out Asians and Brown communities where this practice is also prevalent as well. And it contributed in many ways to sort of stereotype and marginalize communities, immigrant communities in this country who come from societies that are known to have FGM. So I wanted to know, I don't think that I have come across any sort of research data that has updated these findings that the CDC has backed in the US. And I wanted to know if your work looks into this at all or not, and if there's any data.
Very good. Congratulations, Absa. We don't, the US is not one of our focus countries, but we do work with it through networks. There's the End FGM US network, but I'll be happy to connect with you. So I know of, just because of my academic sort of background, you're absolutely right. Most of the FGM data is driven from African immigrants. And there is the calculation is, I feel it's very erroneous, because you assume the FGM prevalence that they have in their countries of origin is equivalent to what's happening here. So if you want to determine the FGM burden, you just kind of round up all the African, descent people and assume that they would have the same FGM prevalence as their home country, which is not correct, because we know when people emigrate to areas where law is enforced or it's not a tradition, it declines. So the likelihood of the FGM prevalences would be much lower. So I don't think I can't talk about this data. Probably you'll find it published. I think the CDC is working on something about the FGM prevalence, and maybe you'll get a publication soon on this. So there is data coming out from that. But yes, we're missing the Asian, the Indonesia. Indonesia is quite ignored. Indonesia is a big one. So that's missing. So have I answered your question? So data-wise, there isn't anything new right now, but just wait, something is going to come out soon. But I also understand that FGM is also performed here in the US among white populations as part of a religious practice of trying to control, I don't know, some sects, extremists. That's what I was told. The extreme sects where sexuality of the girls needs to be brought, and it's really hidden underground. So there is something going on, but we don't know. But this is anecdotal, right?
Absa, do you know anything about that?
Some extreme Christian sect. an extreme Christian sect that does that, and they
That-
support, FGM.
Yeah, there are conservative Christian communities in the Midwest that are known to be engaging in this practice. But some of the people who have been subjected to this practice are coming out to share their stories of this happening to them. And you can even Google it. Equality Now has some of the stories. I've had the opportunity to interact with some of those women who've gone through, who've been subjected to the practice. But I know that even earlier on, just from my own research in the 1950s in the US, FGM was used as sort of a cure for lesbianism. So this is not a new thing in the US among white communities, but the research and data has largely ignored this and made it an African issue. And I think there is a lot of intentionality around that as well in the US in terms of interventions and support for communities that are believed to be impacted by this.
It's also complicated. I wouldn't speak of the US, but also in UK, where it's very much enforced. Any a person coming from Somalia, Sudan, high prevalence, they are asked when you're going on holiday, you're going to perform that. And it's very suspicious. It sort of infringes on people's rights because they force examine. Sometimes force examine just to make sure that the girl has not undergone FGM. So sometimes the law could also reverse, like infringe on your human rights, to privacy. So it can go wrong. It can do.
But you also said when the laws aren't enforced.
That's it.
What's the point of having law?
That's it. But then, it's kind of like these populations are already, they're like a minority. So it's sort of like giving them even a harder time to settle.
Unless you do that for everybody.
That's it, but not everybody's doing it. Yeah.
Great, we should probably wrap up because I
Thank
think
you.
it's time, but thank you so much. Thanks everyone for joining. Thank you, Wisal.
Yeah, I want to add that in the US, so on the visa application, you have to attest that you will not come to the US to, perpetuate FGM or promote FGM or practice FGM. So it is one of the things that you have to check no.
This is new.
Before you
This
come
is
in.
new.
Yes.
Yeah.
And who has to do that, Robbie?
So, any person coming, applying for visa, visit visa, study visa, any of those things, you have to, for the US visa, you have to attest that you're not coming for FGM or to promote it in any way. And just like we have the questions on human trafficking, so now they have those on FGM also. Yep.
Yeah.
Okay.
Yeah. Thank you for saying that.
Yeah,
Yes.
That actually
Thank
seems
you.
like a reasonable.
Yeah. Thank you, Wisal. Thank you, everyone.
Great. Okay. Yeah.